My name is Dolores Pretorius. I'm a professor at the University of California, San Diego, and I'm going to talk today on the AIUM guidelines for obstetrical ultrasound from 2007, which are the basic guidelines we use today. I'd like to talk to you about the AIUM guidelines for obstetrical ultrasound. The newest set of guidelines were adopted by the AIUM in 2007. Previously, the American College of Radiology and the American College of Gynecology had adopted the same guidelines in 2003. These are clinical standards that we can use as practice guidelines. They are minimum criteria for to complete the examination, which has been identified for physicians performing obstetrical ultrasound, and they're often used for a basis of a standard of care for malpractice cases. Well, if you look at the fetus and see how small it is on a scale 9 weeks and then moving up to 38 weeks and all the way to term, you can see how the size of the fetus and the formation changes over time. At 7 weeks, when the crown rump length is 12 millimeters, you can see that we barely have limb buds, a little ear bud, and that the head and neck are really quite large in comparison to the rest of the body. But by 11 weeks, when the crown rump length is 44 millimeters, you can easily see the arms and legs and face, eye, and ear. Now, we talk about different ages for the fetus. From conception, we often call it conceptual age or fetal age or gestational age. And from the last menstrual period, menstrual age. Ultrasound, we often call it ultrasound age. And when we began doing ultrasound, we started talking about the gestational age based on the last menstrual period. So there's a little bit of confusion in what each of these mean. Now, we also talk about what the fetus should be called. From 0 to 10 weeks, it should be called an embryo, and from 10 to 40 weeks, a fetus. We talk about cardiac activity prior to 24 weeks, and we talk about viability after 24 weeks. That's because that's when we think the fetus could survive outside the womb. Now, the introduction to the guidelines state that the fetal sonography should be performed only for valid medical reasons, that we should use the lowest possible ultrasound exposure settings, that the exam, there will be limited exams in clinical emergencies or for limited purposes, like just to check for cardiac activity or fetal position or amniotic fluid index. We can do a limited exam for follow-up after there's been a primary exam, when we're looking to evaluate for growth or reevaluations of specific abnormalities. The guidelines talk about a first trimester set, then a standard second and third trimester, and then the limited exam, as we discussed earlier. Specialized exams are cardiac echoes, detailed exams based on history or biochemistry, like for alpha-fetoprotein or aneuploidy screening, and then specialized exams including the biophysical profile and Doppler studies. Now, the indications for first trimester scan are to confirm the presence of intrauterine pregnancy, suspected ectopic, vaginal bleeding, pelvic pain, estimated gestational age, multiple gestations, confirmed cardiac activity, chorionic villus sampling, embryo transfer, localization or removal of IUD, to assess for certain fetal anomalies. This was added new in the 2007 guidelines that we finally now are recommending that fetuses be screened for anomalies. Also, pelvic masses in the mother or uterine abnormalities, and for possible hydatidiform mole. In the first trimester, the exam can be done transabdominally, transvaginally, or transperineally, whichever is appropriate for that clinical symptom. We are supposed to look for the gestational sac, and we should evaluate the uterus, the cervix, and the adnexa for the location of that sac. We should identify the presence or absence of the yolk sac. We should identify whether the embryo is identified, and we should record the crown rump length measurement if we can see an embryo. And if we cannot see the embryo, then we should measure the sac size. For the presence or absence of cardiac activity. We should be able to see cardiac activity by the time the embryo measures 5 millimeters or greater. If the embryo is less than 5 millimeters, then lack of cardiac activity tells us that we may need an additional exam to determine whether it's going to be a viable pregnancy in the long run. Now, here's a gestational sac, and you can see the crown rump length right here, the yolk sac to the right. This is the gestational sac. And here we have a measurement for the crown rump length in the embryo that measures 33 millimeters. The fetal number must be recorded, and the amnionicity and chorionicity should be documented for multiple pregnancies. So what are we talking about? We're talking about amnionicity and chorionicity being whether they are diamniotic, dichorionic, like we can see in the upper and A here with 2 placentas in this case, and 4 layers of membrane being a thick membrane. The diamniotic, dichorionic can also have a single placenta as seen in B. And C, we have monochorionic amnionicity and chorionicity with a single placenta and a thin separating membrane there with the 2 amnions. And then in D, there's no separating membrane, which is monoamniotic, monochorionic. In this case, in the upper image, we can see a gestational sac with 2 yolk sacs, and suggesting that it is have an amnion in between. And in the lower right, we have twins with very thick separating membrane that is consistent with diamniotic, dichorionic placentation. If we have multiple embryos, then we need to identify how many there are. As you can see in this picture, we see 1, 2, 3, 4, 5 embryos in this single slice. Diamnion, dichorionic will once again have that thick membrane in the late first trimester, as you can see here, with the placenta growing up in between them, whereas the diamnionic, monochorionic will not have a twin peak, and it'll be very thin and wispy here, going out to be identified as a dimo. We should see the gestational sac by 5 weeks, the yolk sac by 5.5 weeks, and an embryo by 6 weeks. Early work showed that if you had HCG levels by 1,000, we should be able to see a gestational sac. By 7,200, we should see a yolk sac, and by 10,800 heart tones. We remembered this as the 1-7-11 rule. Now, a normal sac will have a nice decidual ring. There may be a double deciduous sac seen or may not. It'll be smooth. The embryo, if we're doing transabdominal, should be present by 27 millimeters, whereas if transvaginal, we should see it by 5 millimeters. In general, we do transvaginal in these early pregnancies to be able to identify them. Here we can see a very small crown rump length with a little tiny yolk sac. Now, an abnormal sac will have the sac size, embryo, and cardiac activity inappropriate for those gestational ages that we just recorded. You may see angles in the sac, or it may be collapsed. There may be a poor decidual reaction, and if you do follow-up studies, it'll grow less than 0.6 millimeters per day. A pseudogestational sac seen with ectopic pregnancies can also mimic a gestational sac. So this is an abnormal gestational sac with a large yolk sac and really kind of irregular and angulated edges. This also is an abnormal gestational sac with lots of multiple lucencies within it, and this would be something quite worrisome for trophoblastic disease. Approximately 25% of pregnancies will have vaginal bleeding, and approximately 50% will go on and spontaneously abort. The guidelines tell us that we should look at the uterus, the adnexal structures, and the cul-de-sac for presence, location, and size of myomas and adnexal masses, and that we should look in the cul-de-sac for the presence or absence of fluid. Here we can see a small fibroid sitting right behind this gestational sac at 10 weeks gestational age. And here we can see a molar pregnancy that is seen in this case with a viable fetus along with it, but often our molar pregnancies will be seen in isolation as these multiple large irregular cystic spaces within the uterus. In 2007, the guidelines recommended that we consider doing nuchal translucency measurements in order to assess risk for trisomy 21, 13, 18, and anomalies, such as cardiac defects, because fetuses with congenital heart disease often have an enlarged nuchal fold. There are very strict criteria for doing this technique, and it requires certification in order to be able to take adequate images that can be used accurately for a screening. Basically, if the measurement is greater than 3 millimeters, it is worrisome for a karyotype abnormality. And in this diagram, you can see that the fetus occupies about 75% of the image from the chest up to the head, that we can see the amnion separate from the chorion, and that when we measure it, we need to be very accurate on exactly where we put the cursors, as this is the correct placement. On the left-hand image, we have a normal nuchal measurement of 1 millimeter. In the middle image, it's 3, which would be borderline to abnormal, and we would need to correlate it with our blood test to be able to give a specific risk. And then on the right, you see the 10 millimeters, which is clearly abnormal and would be very worrisome for a karyotype abnormality. Now I'd like to go on to the second and third trimester guidelines. The indications for second and third trimesters is much longer than for first. You can see estimate gestational age, fetal growth, vaginal bleeding, pelvic pain, incompetent cervix, fetal presentation, multiple gestations, adjunct to amniocentesis, size dates discrepancy, pelvic mass, suspected hydatidiform mole, cervical cerclage placement, ectopic pregnancy, fetal death, uterine abnormality, fetal well-being, amniotic fluid abnormalities, placental abruption, external cephalic version, premature rupture of membranes or preterm labor, abnormal biochemical markers. Abnormal biochemical markers, follow-up for fetal anomaly, follow-up for placenta previa, history of previous congenital anomaly, fetal condition in late registrants for prenatal care, to assess for findings that may increase risk for aneuploidy, that is a new one for the 2007 guidelines, and screening for fetal anomalies. We need to look at fetal cardiac activity and notice whether the rate is abnormal and irregular or whether it's normal, and that rhythm should be reported in the report. We need to identify the fetal number again and the presentation. The presentation will be cephalic in the upper first line of box A. In the second, it'll be breech. The third, it'll be a transverse lie with the head to the left. And then the next one would be transverse lie, head to the right. And you can see the variations of all these need to be dictated in your report. Multiple pregnancies, just like the first trimester, we need to identify the amnionicity and chorionicity, because this makes a great impact on how frequently we could study these patients. Need to study them in order to find the complications of twins, and they do vary significantly based on the amnionicity and chorionicity. We need to do a comparison of fetal size and estimate the amount of amniotic fluid on each side of the membrane. We generally do a single pocket. The guidelines tell us we should at least say whether they're increased, decreased, or normal, and they do suggest that we should look at the genitalia and report it. And that's because the genitalia will help us with the amnionicity and chorionicity. If they're different, a boy and a girl, it is likely that they came from two eggs, diamniotic, dichorionic. This is true most of the time, but occasionally patients with infertility do not read the books, and they occasionally have came from the same egg and still have different gender. We also look at the placenta. If there's a single placenta, we don't know, but if there are two placentas, we know that it's diamniotic, dichorionic. And then lastly, we look at the membrane. When we evaluate that membrane, we need to determine whether it's thick, thin. Some people will actually look at the number of layers, but the twin peak is very important in making this differentiation. Now, Dr. Sebayer called it the lambda sign. Other people call it the twin peak. It basically is when placenta is growing up between the two layers of the amnion. Whereas in a monochorionic placentation, you can see that the placenta cannot grow up in between the two layers of the amnion because that chorion is holding it back. Now, if you look at this picture of the placenta, it makes sense why you sometimes will see the peak and sometimes not, because if you have a section on the ultrasound coming through here, you might not see any twin peak, whereas if you went right through here, you would see a very nice twin peak. So the point is that the placenta grows up in patches. It doesn't grow up along the entire membrane. On the left, we see a twin peak and a diamniotic dichorionic placenta, and on the right, we see a very thin wispy membrane floating adjacent to the limbs of this fetus, and we see no twin peak. This is a diamnionic monochorionic twin. Triplets will have variations on the theme of amnionicity and chorionicity, so that you can see a very thick membrane between B and C, so that would be a di-di. And then on the, there's either no membrane, which you can't see here, or there is a very thin wispy membrane going in between these twins, and that would be important. We need to compare the size between the two twins in order to assess them for intrauterine growth retardation between the two. Amniotic fluid, we use the single deepest pocket in order to assess these methods. Certainly, if the pocket is less than 2 centimeters around a fetus, that is worrisome. In general, when we look at the amniotic fluid index in singletons, if it is between 5 and 20 centimeters, it's normal. If it's less than 5 centimeters, we're quite concerned about being oligohydramnios. And if it's greater than 20 centimeters, and some people will actually use 25, then we are worried about polyhydramnios. When you look at the 4 quadrants, you basically take a distance, just drop down in order to measure those 4 quadrants, and then a nice curve to the right we see of what is considered to be within normal limits. And you see why the 20 to 25, it's not perfectly straight throughout gestation. We take that measurement by dropping the line down, and we must have at least 1 centimeter of fluid pocket where we measure that in order to get the amniotic fluid calculation. We take those 4 quadrants and we add them up to get the AFI. The placenta, cervix, and cord also need to be evaluated. We need to state where the placenta is and the appearance of it, its relationship to the internal cervical os. And also we note that the position early in pregnancy may not correlate very well with what will be late in pregnancy, because as the uterus grows and enlarges during gestation, that placenta often moves up and out of the lower uterine segment as it stretches, and what early on looks like a placenta previa later on will not be at all. So anytime we see an early diagnosis of possible placenta previa, we want to bring them back at about 28 weeks. The guidelines also suggest that we should look at the number of vessels in the umbilical cord, and we should also assess for cervical shortening with transvaginal or transperineal scan. So this is a low-lying placenta that is approximately 1.8 centimeters from the cervix, which we can see over to our right here. This is the urinary bladder. So we would call that a low-lying placenta. Now this is a 19-week scan, and you can see that it looks like a placenta previa on transabdominal, and when we go to transvaginal scanning and see the cervix, we can see the placenta is indeed covering the cervix, and that would be placenta previa, and we would recommend a follow-up at 28 weeks. Now we do look at the placental cord insertion into the umbilical cord insertion into the placenta, but this is not yet in the guidelines. We feel this is important in looking for filamentous insertions. The cervical length measures 4.9 centimeters in the case here shown with the bladder anteriorly. And in general, if your cervix is over 5 centimeters, it's just a little bit too long. Now, if you have a question, you will need to go to transvaginal, as you can see here, and this cervix measures 2.2 centimeters, and you can see the membranes bulging down into that cervix. Ultrasound should also be used for assessment of gestational age. The crown rump length is the most accurate in the first trimester to assess for gestational age, but as you go on to the second trimester, we use the biparietal diameter, and that should be performed at the level of the thalami and the cavum septum pellucidum. The cerebellar hemispheres should not be visible in the biparietal diameter, and we should measure from the outer edge of the proximal skull to the inner edge of the distal skull, as you can see here in this diagram. The cavum is right up over here, and this is the midline falx, and there's leading echo to leading echo. Now, just recently in 2008, Peter Callan wrote a paper that was very helpful to us in noticing that the cavum has no echoes within it, whereas if you take it a little bit low, you are really in the fornices, and then it is these fornices that tell us that we're a little bit too low in the fetal head in order to call it the accurate biparietal diameter. And why do we care? Because we care because you can have agenesis of the corpus callosum with an absence of the cavum, and that may be a very important sign for an abnormality of the brain. When we look at gestational age, we not only do the BPD, but we also look at the head circumference and measure it at the same level as the BPD around the outer perimeter of the calvarium. And here's another measurement showing the head circumference, and you can see that this head is a little dolichocephalic. It kind of is boat-shaped and looks a little bit flattened in the middle, and that is still a normal appearance to a head. It's just going to have a more accurate head circumference than biparietal diameter. The femur length is the next structure we assess gestational age with, and it's pretty reliable after 14 weeks. It's most accurate when measured with the beam of encination being perpendicular to the shaft as shown in this picture, and excluding the distal femoral diatheses. We also look at the abdominal circumference for assessment of gestational age, measuring at the skin line. It's important to get a true transverse image at the level of the junction of the umbilical vein, portal sinus, and fetal stomach when present. This abdominal circumference is used to estimate fetal weight, and it may allow detection of IUGR and macrosomia, and this is the level we like to take it with the stomach and the hockey stick or the umbilical vein coming in. It's very important to look and see where these calipers are put, particularly in the third trimester, as it's really easy to underestimate the size of the abdomen if you're not careful. Now, in general, we use a variability of dating rule that in the teens, it's within 1 week of variability. In the 20s, it's within 2 weeks. And in the 30s, it's within 3 weeks. But there's a caveat to this that if you have a prior ultrasound, then you should be growing within about a week of your original ultrasound dates. Intrauterine growth restriction, the causes are congenital anomalies, infection, maternal nutrition, maternal hypertension, maternal smoking, and drugs, just to name a few. In general, how do we make this diagnosis? We do serial ultrasound studies. We find a small biparietal diameter or a small abdominal circumference. We look at the head to abdomen ratio, and if that's not correct on the tables, then that's worrisome. We look for oligohydramnios and abnormal Doppler studies. There's two types of intrauterine growth restriction. Number one is symmetrical, where both the head and the body are delayed, which tends to be more frequently in the second trimester, whereas asymmetrical intrauterine growth restriction is caused in the third trimester, and it has head sparing with the body being smaller and the head being more normal. In general, the symmetrical types are much less common, only 25%, and the asymmetrical ones are more common. How do we estimate the fetal weight? We use those parameters, the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. We look at interval measurement changes, and these can be performed every 2 to 4 weeks depending upon what time in gestation it is. We usually do them further apart when we're in the second trimester and closer together in the third trimester. The error may be as high as 15% in estimating the fetal weight. At our institution at the University of California, San Diego, we take 3 measurements of the abdomen circumference in the third trimester if it's an abnormal number or if the patient is diabetic. We do look at the growth curves in order to assess for fetal growth in the third trimester, and these would be fairly normal measurement up on the left, but you look at the abdominal circumference, it's going up above the 95th percentile in the curve on the right. Okay, we also need to look at the maternal anatomy, to look at the uterus, the adnexa, and once again, the presence, location, and size of myomas and adnexal masses. So this is a left ovary that we can see is a normal structure, whereas this is a fibroid that is living in the retroplacental region in the upper left-hand corner in a pregnancy at 19 weeks. We can see this fibroid over here under the placenta as well. When they're retroplacental, they have an increased incidence of abruption when it gets closer to delivery and intrauterine growth restriction. This is kind of interesting fibroid kind of sitting right inside the amniotic fluid. Now the fetus also has to be looked at for an anatomic survey, and this can usually be done after 18 weeks gestational age. There will be technical limitations in some patients that are larger or when the fetus is an unusual presentation, and follow-up may be helpful in those cases. So we're going to go through the fetus from head to foot. When we look at the fetal head and neck, the guidelines tell us we need to look at the cerebellum, the choroid plexus, the cisterna magna, the lateral cerebral ventricles, the midline falx, the cavum septi pellucidum, the upper lip, and the nuchal fold, both of which were added in the 2007 guidelines. So we look over at this picture of the head, and you can see the cavum septum pellucidum. We can see the cisterna magna with the posterior fossa, and you can see the nuchal fold sitting right back here. You measure from the edge of the cranium to the edge of the skin there, and you do need to be at the level of the cavum. The choroid, you need to measure the ventricles from the medial wall to the lateral wall where you see 2 bright echogenic lines. Once again, the cavum septum pellucidum with no central echo within it. The palate is not yet in the guidelines, but it is something we do at the University of California on everyone, and this is the palate with the primary palate here and the secondary palate posteriorly and in the back. The lips, as we said earlier, have been added to the guideline. This is the upper lip, and you can see the 2 nostrils right here of the nose. This would be the lower lip. The nasal bone is not yet in the guidelines, but it is something that is becoming more commonly done, and we do it on all of our patients in our lab for the risk of aneuploidy and Down syndrome specifically. You can see that this is the chin of this fetus. After the face, we go look into the chest, where we look for the 4-chamber view of the heart, and we attempt to evaluate both outflow tracts. The 4-chamber of the heart is here. You can see these diagrams showing the normal axis of the heart, 45 degrees axis when you look at the spine towards the sternum. And you can see the 2 atria, the 2 ventricles, similar in size. The heart occupies about a third the size of the chest. We look for an intact septum and an intact crus, as well as the position of the valves themselves. So we should try to get 1 rib on each side to get a normal 4-chamber. Not always easy to do. You can see here we have a normal 4-chamber and we only have 1 good rib, so it's not always necessary, it just can be helpful. There is the crus. You can see that the tricuspid valve is just a tiny bit lower than the mitral valve, which is important. The left outflow tract comes from the left ventricle. That's from the aorta sweeping along here, and that's very important to look for VSDs as well as malalignment, because if the aorta goes over into both ventricles, then we worry about transposition of the great vessels, truncus, or double outlet right ventricle. This is a picture of the right ventricular outflow tract. We call this the sausage and the egg view. We like that. Radiologists love food. Here is the sausage and here is the egg, and that's the aorta in the middle with the pulmonary artery here with the pulmonic valve coming right out of the right ventricle. You can see the right atrium here with that tricuspid valve, just like in the diagram to the left. We move on to the abdomen. We look for the present size and situs of the stomach, meaning whether it's on the left or the right. We look at the kidneys, the bladder, the umbilical cord insertion site into the fetal abdomen, and the umbilical cord vessel number. So here we have the stomach on the left and the spine is over here, and you have to know the position of the baby, that this is in a cephalic position with the spine to the left and the left side down. These are the kidneys, and in order to identify the kidneys, we need to see a little bit of Gerota's fascia here or a little bit of the pelvis, and there's a little bit of the pelvis in order to say that we are certain that there are kidneys there. And there's a nice bladder fluid-filled collection in the pelvis. At 10 weeks, we can see some bowel that herniates out into the cord. This is normal physiologic herniation. It should be back into the fetal abdomen by the end of the 11th week. So here you can see in the same fetus at 12 weeks, it's back inside the abdomen. So that is normal. A normal cord insertion later on in the second trimester, we should see fluid on both sides of the umbilical cord. When we go down to look at the vessels in the cord, we usually take this picture, which is a color picture using power Doppler, showing the two hypogastric arteries alongside the bladder as they enter into the fetus, and that tells us that there is a 3-vessel cord with 2 arteries. Now, the iliac arteries are similar to the hypogastric arteries, and so it is important to make sure that you know where the vessels are coming in. These would be the iliacs, whereas these would be our umbilical arteries coming in. Now, the umbilical cord can also be identified within the amniotic fluid, and you can see those 2 arteries and 2 veins in both of those pictures. We talk about them as the Mickey Mouse ears. We need to also look at the spine, looking at the cervical, thoracic, lumbar, and sacral spine, and the extremities, the legs and the arms. Now, when we look at the spine, we need to not only look in longitudinal, where you see the picture in the upper left where it looks like a zipper, and you can see all of those vertebral bodies paired. As you look at, these are paired as you go along, so that if they're abnormal, you would see it. The thoracic spine, we need to look at the entire spine in transverse at all, where we count 1, 2, 3, coming down 1, 2, 3, and then to the sacrum once again, and we also look at the skin on top to make sure we don't have any spinal defects. The upper extremity, we're supposed to look at those extremities, so we take a picture showing the humerus and the radius and ulna with the hand below. And we don't take open hands on everyone, but we do try to in some patients who are at increased risk. The lower extremity, we take pictures of the lower leg and of the ankle. We need to take pictures of the gender in multiple gestations, but in singletons, it's not necessary in the low-risk pregnancies, but most of our families in our culture would like to know the gender, and they feel much better if you can tell it to them. So I'd say about 80% of patients want to know their gender, and it'll all depend upon your patient population. This is a male with the 2 legs spread, and you can see the scrotum and the penis right in the middle. Now, the guidelines also tell us that we need to record a permanent record of our images. and we need to record the measurements so that when we take that picture that comes up on the computer, we need to actually print it out some way. It's also important to label the images with the exam date, the patient ID number, and if appropriate, the image orientation. For example, whether it's sagittal or transverse, and also whether it's right or left-sided. Since the fetus moves around, you don't really know if it's an abnormal right kidney. We'd like to know that, and that there needs to be a written report. The equipment that we're supposed to use, the guidelines tell us that we can use real-time scanners, transabdominal or transvaginal, that the transducer should be using the appropriate frequency for whatever you're trying to look at. That real-time sonography is necessary to confirm fetal life through observations of fetal cardiac activity and active movement. Now, for fetal safety, ultrasound is considered to be safe, but we should only perform it when there's a valid medical indication. And that's because we want to use the lowest possible ultrasound exposure settings when we can, to use the same principle, the ALARA principle that we use for radiation, which is as low as reasonably achievable. Now, ultrasound does have bioeffects, and the bioeffects are predominantly related to thermal effects and mechanical effects. The energy levels depend on the machine settings that you use. The MI, which is the mechanical index, and the TI, which is the thermal index, are both listed on our images. Now, some images will only have the mechanical index on them, and some of them will only have the thermal index on them. But both of these we want to try to keep below 1.0 if we can. Now, when we turn on color, we will always increase those indices a little bit, particularly the thermal index, and we want to use color very briefly when we turn it on. Now, the bioeffects studies that have been done with ultrasound are all done based on old limits of 94 milliwatts per centimeter squared. But as the technology has developed, we now have much higher limits. And we use 720 milliwatts per centimeter squared, but all of the bioeffects studies have not been repeated because basically in our culture, greater than 80% of women get ultrasound exams, and we can't really do those same studies that were done early on. So the main point for you is that you don't sit and scan a fetus forever. You mainly try to get in, look at what you need to look at, and then get out. Because raising the temperature in the fluid around the baby is not healthy for it, and we don't want to do it for prolonged periods of time. The AIUM tells us that the promotion, selling, or leasing of ultrasound equipment for making keepsake fetal videos is considered by the FDA to be an unapproved use of a medical device in the United States. Use of a diagnostic ultrasound system for these purposes without a physician's order may be in violation of state law or regulations. Policies and procedures related to quality, patient education, infection control, safety, and equipment performance monitoring are all a part of those guidelines, and they must be developed and implemented according to the AIUM guidelines. So there are additional guidelines telling us how to sterilize our transvaginal probe, for example, and about safety beyond what we've gone over today. That's the end, and thank you very much.